be here, as you know, so we'll just cancel. No. All right. We'll try to scoot through this today and get out so everyone can get out and enjoy this. It's also, Mark was noting that it's a little bit thinner crowd than usual because we've just completed a recertification cycle, so everybody figures they can slack off for a time or two. But you can remind your friends that they do owe me the tape review. Before we get going, I want to introduce Dr. Marlo Macht. Marlo is a former paramedic. I guess you still have paramedic registry, and he's completed a medical school and a residency in emergency medicine and a fellowship in EMS at Denver. And Marlo will be joining me and Mark as at the time being an assistant MPD. He's going to be working, or is working now, had his first couple of shifts at Legacy Salmon Creek. And so he'll also be liaison with between EMS and the Salmon Creek staff. So I think Marlo will be mostly involved with doing quality assurance kind of stuff, doing some lectures for you so that you won't be totally bored listening to me all the time. And also expressed some interest in doing some ride-alongs with various groups. So we'll have them out with AMR and CAMAs. I don't know about North Country, but that's another story. So, any rate, so welcome to Marlo.
Welcome. Thank you to Dr. Weber. I've always heard nothing but wonderful things about this system. I'm really grateful to have the chance to work with you guys. I was working with y'all at places CDE or around this, just so you know if I can be available.
So today we're going to talk toxicologic exposures, overdoses, some updates on a few things. We looked at this. This is almost exactly 3 years since the last time we did it, which is, time flies when you're having so much fun. I thought it was earlier than that, but let's see if this thing works. There we go. So, remember we have what is a toxidrome? A toxidrome is a constellation, a group of signs and symptoms usually observed after exposure to a toxic substance. Generally, they're physiologically grouped abnormalities, which might include vital signs, changes in skin and mucous membrane, changes in pupil size, changes in the cardiovascular system, either tachycardia or bradycardia, hypotension, effects on the GI and GU system, and neurologic findings, mental status. Now, very busy slide, but this is the type of toxidromes and the kind of main things we'll be talking about today. So, sympathomimetic or adrenergic syndrome. Such things as cocaine and methamphetamines. Clinical features: agitation, diaphoresis, hypertension, hyperthermia, dilated pupils, tachycardia. In other words, hyper. So hyperadrenergic syndrome. We generally treat that with midazolam or any good benzodiazepine. Midazolam is what we're carrying. The opioid toxidrome from heroin, hydromorphone, methadone, oxycodone. Remember, this last year, Washington had as many deaths from prescription narcotics as from illegal narcotics in overdose. Whoop. So, depressed mental status, hypoventilation, and that's what we're really treating. You don't really need to overtreat depressed mental status. It's whether they're ventilating or not adequately as to whether you're going to give them the big bang or the big dose of Narcan. Constricted pupils. Anticholinergic from pesticides, carbamates, organophosphates. You get everything from the what's called the muscarinic side effects: diarrhea, urination, bradycardia, bronchospasm, bronchuria, the SLUD syndrome. To the nicotinic side, these things come in the cholinergic things come in two flavors: muscarinic and nicotinic. And most of your nerve gases and most of the organophosphates have both nicotinic and muscarinic side effects. The nicotinic is the reverse of what you see in the muscarinic side. You get tachycardia, weakness, fasciculations of muscles, hyperglycemia, interestingly, and mydriasis, big pupils. That's why, but these things they have both things in them, both side effects, and if you just suppress one, you get stuck with the other. So that's why for treatment of your nerve gases, you have the two-dose thing. You have atropine and you have tupam, which is the antidote for the nicotinic side. You can't hear it with a simple. So, the toxidrome for cardiotoxic drugs, beta blockers, calcium channel driver, bradycardia, conduction problems, and hypotension. Sodium channel blockade is your tricyclics and certain antiarrhythmics, and of course, altered mental status, hypotension, seizures, wide complex tachycardia. Those things fall together with those kind of toxidromes. So, some specific poisons to get into. Cyanide. Most of your exposure to cyanide would be either industrial or from smoke inhalation from hydrogen cyanide release from combusting nitrogen containing polymers. Things like certain vinyls, certain wool products. But most of our exposure around here would be, most of our main concern is industrial. And it's either skin exposure to cyanide salts or inadvertent ingestion of cyanide salt or the release of hydrogen cyanide accidentally from a industrial exposure. Suicide and homicide is still possible in cyanide overdose if they have an occupational access to cyanide salts, or it naturally occurs in certain plant glycosides, apricot pits, bitter almond, even cherry pit has not cherry pit, but peach pit has a little bit of cyanide salt. Nobody can eat it, a peach pit. They grind up used to grind up toasted apricot pits to make amygdalin, which was thought to be a treatment for cancer. Certain cosmetic products have some cyanide in it for some odd reason. All tobacco smoke has a small amount of cyanide in it. So there's a very low dose exposure there. And cassava plant also has cyanide. Now, with cyanide poisoning by ingestion, symptoms occur within minutes. However, it takes a fair amount. It takes 140 to 250 milligrams untreated. That's the LD50. In other words, you'll kill 50% of the animals that you feed that amount to. By comparison, something like Valium, the LD50 is about a gram per gram of body weight. So it's a fair difference. If you take this in the form of a plant kind of substance, or if you use if you drink nail polish remover, which has a acetonitrite solvent in it, this has to be metabolically activated to become cyanide, hydrogen cyanide. So apricot peach pills, amygdalin, has to go through. You have to eat it, ingest it. Has to be partially digested by stomach acid and then absorbed as the cyanide. Very slow process. Sodium nitroprusside, which you guys don't use, we still use occasionally in the emergency department for acute hypertensive crises. That also has to be metabolically activated. Cyanide poisoning is a constellation of symptoms. Pulmonary starts out with dyspnea, tachypnea, and then apnea, depending on the length of time of exposure and the amount of exposure. Cardiovascular start out initially with tachycardia, hypertension, followed by bradycardia and hypotension as the symptoms progress and as the exposure progresses. Then cardiovascular collapse, ultimately asystole. CNS starts out with headache, drowsiness, seizures, and then coma. So initial low-dose cyanide poisoning, the patient would be dyspneic, probably tachypnic, tachycardic, maybe hypertensive, and complaining of headache or drowsiness. Now, signs of poisoning. First of all, you need to assess the scene and decide whether this is, an industrial exposure, and you have a significant chance of cyanide poisoning, or if you actually know that, or they actually know that a cyanide gas was released, or the person was covered with cyanide skin-wise. Then, has the patient got an altered mental status? Do they have seizures, coma, tachypnea or apnea? There's shock, vomiting. Obviously, first, hyperventilate the patient, 100% O2, assist ventilations, intubate as needed. And we're going to be changing your cyanide antidote back to the good old days. Remember the days of the Lilly cyanide kit, where you'd first give them a little amyl nitrite. We threw that out after a few years, and we found out paramedics liked the amyl nitrite for other things. Yeah. And then you treat them with a nitrate to cause methemoglobinemia. So you poison the poisoned person with nitrites first, because that shifted the cyanide out of the hemoglobin and off the intracellular binding, and then, but to do that, you had to create methemoglobinemia, and that's kind of a downside. So it turns out that all the studies have shown that even though it doesn't work as well as what I'm going to as the cyanic kit, sodium thiosulfate binds with cyanide to make sodium thiocyanate, which is a soluble salt, which is non-toxic. And it's cheap. So we'll be putting the sodium thiosulfate back on your kit. So, and you take a 50 cc's of a 25% solution for an adult, infuse that over 10 to 20 minutes, if you think you have cyanide. Now, concurrently, you probably have concern that this is carbon monoxide poisoning, because the patient will be exposed to smoke You know, most of our exposures turn out to be in a house fire. And you think, well, maybe this person who's apneic and appears to be dead has got cyanide poisoning as well as carbon monoxide poisoning and smoking. Usually they're just dead and they don't have cyanide poisoning. Turns out the burn center has very few people they get with cyanide poisoning from house fires. Extremely low. So much that they hate the cyanic kit, and I'll tell you why in a minute. So if you think this is a cyanide poisoning, then you can use the sodium thiosulfate. That will be in your, we'll put out the new orders September, then the update. So you will have and you'll have clear and we'll include that in the lecture in September. Child's dose is terrible. It's about 1.65 mils, which is ridiculous per kilo. Should have just put 2 and guess at it. Now, other treatments. Hydroxycobalamin. All the studies show that it works better for cyanide poisoning than does sodium thiosulfate. It's now $1,100 per dose. And it goes out of date after a year, and the manufacturer won't buy it back from you and replace it with a new one.
So AMR won't be carrying that?
No, and nor will the fire departments, because it's too expensive. I mean, you know, you put it, even if you just put it on the soup rigs, you're talking, you know, $3,000 or $4,000 or $5,000 a year for something you're not going to use. So, but hydroxycobalamin does bind with cyanide, makes cyanocobalamin, which is basically B12, vitamin B12. It's excreted in the urine, has minimum side effects. However, it does a reddish discoloration of skin and mucous membranes, transient hypertension, may cause anaphylaxis, which is rare. You know, how would you tell if a person is, you know, laying there dead and you get anaphylaxis, right? High dose administration requires, takes at least 5 to 10 grams to treat. The hospitals have it. We are going to try to encourage the likely sources of this you know, the plants where they use hydrogen cyanide salts and they use hydrogen cyanide for etching, basically. So the silicon plants, we're going to try to encourage them to keep a dose for their employees. They've had very low exposure rates. But the other trick with this, with the cyanide, and why the burn, with the hydroxycobalamin, why the cyanicates, why the Oregon Burn Center just hates it, because once you treat it, because it changes the colorimetric character of blood also, and so they cannot get a pulse ox accurately for up to 3 weeks. So that makes it very difficult. They have to do blood gases, arterial blood gases, to check, you know, where the patient is oxygen-wise, which is kind of a problem. One of the tricks with hydroxycobalamin, if you're going to use it, you have to establish the carbon monoxide level with your Massimo or other, you know, colorimetric unit, because that also will be inaccurate if you use the hydroxycobalamin. So another good reason not to have it just laying around in the field, because too expensive, confuses. You wouldn't be able to tell what the person accurate, you know, how you're doing oxygenating the patient. So we'll stick with the easy stuff that's cheap first. I think by comparison, a dose of sodium thiocyanate is about $4. It's a significant thing. So, carbon monoxide poisoning. Carbon monoxide is incomplete combustion of carbon containing material. Most of the time you get CO2 if you have complete combustion. Unintentional exposure is common in northern climates because we live inside and we have vented and or poorly vented furnaces. We have furnaces or heat sources that do not put out carbon monoxide and completely combust the things. Remember several years ago we had a patient who was living in a garage and heating the garage with his barbecue, a propane barbecue. That gave him a fairly significant carbon monoxide poison, and he was also hypothermic, which was kind of interesting. About 500 deaths per year are non-fire related. Obviously, carbon monoxide is common in a fire, closed space fire exposure because you've got incomplete combustion in an enclosed space. But non-fire related or fire related deaths are hard to tell how many of them die because of plain ordinary smoke inhalation and asphyxiation, and how many may have carbon monoxide poisoning, and how many may have carbon monoxide poisoning and asphyxiation. Most of your sources of carbon monoxide include engine combustion, gas and coal heaters, burning of rainforests even, cigarette smoking. All cigarette smokers have a measurable level of carbon monoxide, and that's why if you're a fire guy and you're being and they're checking you after putting out a fire, and you've got and trying to see if you've got carbon monoxide exposure, you will have probably up to 3 parts per million, a 3% type of reading on your mass amount if you're a smoker. Paint stripper, methyl chloride vapor is also high in carbon monoxide. That's why they tell you on the can to keep the windows open, work in a well-ventilated space. So odorless, clear gas. Now, what you smell when someone kills himself by running their car with a hose into their car, what you smell is the other things in the exhaust. It is not the carbon monoxide. Small amount of carbon monoxide is produced normally during metabolism of hemoglobin to bilirubin, carboxyhemoglobin. Now, I'm always sort of like with cyanide. It's interesting that some things like vitamin B12. Why do we have a vitamin that has cyanide in it as part of the thing? What an odd thing. Just why do you also have produce carbon monoxide when you're normally metabolizing hemoglobin to bilirubin in the liver? Carbon monoxide and oxygen have different binding affinities for the respiratory enzymes. Hemoglobin has a almost 300% greater affinity for carbon monoxide. Myoglobin, 20 to 25% greater affinity for carbon monoxide. Carbon monoxide, when you bind to hemoglobin, reduces your oxygen transport and availability to tissue. It basically shifts our wonderful oxyhemoglobin dissociation curve to the left. And all that means, after all these years of looking at the damn oxyhemoglobin curve, is that when you get when a patient becomes high in carbon monoxide or low in hydrogen ion, in other words, their pH goes up, so they become more alkalotic, or decreased temperature. It means that blood cannot give up oxygen to tissues, whether they're acidotic tissues or not. The beauty of the oxyhemoglobin curve is it just shows that hemoglobin is a perfect thing to carry oxygen and give it up to tissues that are acidotic or too warm or high in diphosphoglyceride. But with carbon monoxide, it cannot give up oxygen to the tissue that needs it. Clinical findings in carbon monoxide poisoning: brain and heart are the most affected because they have high oxygen utilization. Neurologic symptoms start out with fatigue, malaise, flu-like symptoms. That's why carbon monoxide poisoning is often confused with the flu. So your job when you go in, when you see that the 5 people in the family are sick, the dog is sick, the cat is sick, the bird is not doing well, think maybe this isn't just the common flu. Bird flu. Right? No. Fatigue, malaise, flu-like symptoms. Nausea, vomiting, difficulty thinking, concentrating, emotional lability, dizziness, weakness, and moving on to paresthesias, funny sensations in the extremities, skin, moving on to stroke and coma, seizure, respiratory arrest. Cardiovascular system, because you're going to have all the ischemic symptoms, ischemic chest pain, palpitations, dysrhythmias, mottled skin, poor capillary refill, hypotension, cardiac arrest. There will be a few secondary injuries from carbon monoxide poisoning, including rhabdomyolysis, so they're at risk for acute renal failure, ultimately. Non-cardiogenic pulmonary edema, multi-organ failure, disseminated intravascular coagulation, what's called dermal pressure wounding, due to basically it's ischemic. It's like developing bed sores, pressure sores, because the skin has become ischemic, and so it's very sensitive to any pressure. Shock due to vasodilatation and to decreased cardiac output. Acute renal failure, mostly related to that rhabdomyolysis, and ischemic brain damage. Carbon monoxide symptoms are often made worse by the natural attempt of us to escape a burning building, a fire. So acute exertion under reduced oxygen delivering capacity. Also maybe a problem with trauma, increasing oxygen demand, other drug ingestion that the patient may have had, or exposure to cyanide, burns causing increased oxygen demand, myocardial ischemia, so older persons are at more risk, cerebral vascular disease, older persons are at more risk, and smoke inhalation in general. Treatment: 100% oxygen, intubate if they're apneic or deteriorating in front of you, and then manage symptomatically. So from your orders, carbon monoxide poisoning suspected, if you suspect it, due to altered mental status with multiple patients or sick pets at the same location, or smoke inhalation or exposure. 100% O2, determine carbon monoxide level with the Massimo device. If cyanide is suspected, determine carbon monoxide level prior to treatment. Now, that's only if you're going to worry about using cyanocobalamin. If they have a CO level between 3% and 25%, and neurologic symptoms, headache, dizziness, nausea, syncope, seizures, etc., treat and transport, obviously, to an ED. If they have an SpCO2 greater than 25, divert to hyperbaric chamber. Where's the hyperbaric chamber? Providence, the only one around that's big enough to die of a pain. Now, we have 2 or 3 outpatient hyperbaric units at Southwest in the outpatient portion of Southwest to treat wounds, well, primarily. It's in the wound care thing. They are not big enough to die of a because a patient who's got more than 25% CO and they're not doing well. They need attendants. They need people inside that unit with them. Maybe to ventilate them, maybe to monitor and treat other things. So they have to dive. You have to dive someone with them. You take them down to about 3 atmospheres. Hyperbaric oxygen works by increasing the atmospheric pressure, which causes more oxygen to be dissolved in serum. Doesn't include your hemoglobin, doesn't improve your, per se, it doesn't include the hemoglobin saturation, but it increases the oxygen actually physically in solution in plasma. That by itself helps to displace carbon monoxide off the hemoglobin. So ultimately, you do increase your SpO2. It reduces the half-life of carboxyhemoglobin by 3/4, by 75%. That's even over 100% oxygen. Increases delivery to ischemic tissue, which is why we use it in wound therapy. Enhances carbon monoxide elimination from the hemoglobin just because you've got a lot of it now in the plasma, so it'll ultimately displace it. And then lessens carbon monoxide induced reperfusion injury to brain, to heart. So indications for hyperbaric oxygen treatment would include, a definite indication would be abnormal neurologic exam, particularly after treatment with high flow O2. History of loss of consciousness or near syncope. History of seizure or coma. History of hypotension during or after exposure. Myocardial ischemia. How do we know that? You do a 12 lead. It's part of the protocol for all these people. Prolonged exposure and pregnancy with any amount of elevated carboxyhemoglobin. Okay. Questions about CO? Okay. Switching gears to a different poisoning, anaphylaxis. Anaphylaxis, a severe systemic hypersensitivity, multi-organ involvement caused by release of mediators and mast cell degranulation. Woof. Pretty all-inclusive. Hypersensitivity itself is an inappropriate immune response to an antigen. Yeah. risk factors for anaphylaxis, you can't, de novo, you can't look at a child, at an infant and say, well, you're going to be at risk for anaphylaxis, because it's not identified, you can't identify the risk for anaphylaxis by age, race, gender, occupation, or geography. Indeed, most beekeepers I know have been stung many, many times and have never had reactions to bee stings. So your occupation as a beekeeper doesn't set you up for anaphylaxis. It's determined probably by, it's totally determined by your genetics. However, fatal anaphylaxis increases, your risk of fatal anaphylaxis increase with poorly controlled asthma. Of course, asthma is at least in large part based on allergy, based on hypersensitivity, and previous anaphylaxis. If you had anaphylaxis once, you're going to get it again, which is why we get people anakits or EpiPens if they've had an anaphylaxis to bee sting or to foodstuff. Anaphylaxis recurrence is about 40 to 60% for insect stings. Probably it would be higher if it was the same bug that, the same wasp or the same honeybee that stung you. The second time, you have to have a sting to start with. Wasps and honeybees are not the same genus. They don't necessarily cross-react. However, to somebody who gets stung, to the mom who has her kid get stung, they always know it's always, they're anaphylactic to bees. They just say bees or wasp, and they always got to be the same thing. 20 to 40% for radiocontrast dyes. 10 to 20% for penicillin. Now, actually, that's on the low end of the spectrum, and most people who tell you that, well, we ask, if someone has a penicillin reaction, what do you mean, a penicillin reaction? You usually say, oh, when I was a kid, when I was about 5, I had some amoxicillin, and I broke out with a rash, which is really common. Amoxicillin rashes, particularly associated with other intercurrent viral illnesses, are very common, and sometimes amoxicillin causes a rash. Anyway, it's not really an anaphylaxis. Anaphylaxis to us means a real reaction, a systemic, multi-organ system. Your skin is just one organ system. So if you have skin itching or wheals or a rash, and it's usually a fine papery rash, if you have if you have bronchus constriction, aggravation of asthma, laryngeal edema, stridor, that might be anaphylaxis. Hypotension, cardiovascular, relative collapse, that might be anaphylaxis. But a skin rash is not anaphylaxis. Penicillin is very low. Most common causes of anaphylaxis are, though, antibiotics, insects, and foods. So much so that many places, many school systems ban peanut products, peanut butter. They seem to be coming back now. Other nuts, are in there. Some people are allergic to nuts. Peanuts are not nuts, by the way. Peanuts are legumes, are related to peas. So, most common agent in pediatrics, though, is food, because that's how kids mostly get stuff into their system, is by ingesting it. Classic anaphylaxis requires 2 exposures to the antigen. The first one sensitizes you, and it requires the the activation of your full immune system, which includes the T cells and B cells. So the antibody is produced, foreign substance. Generally, the highest ones are proteins. The next highest ones are some of the protein polysaccharide combination things. But you produce an antibody. How anaphylaxis works is a foreign substance comes in. Let's say it's a penicillin, and it binds to cells or gets into the cell. It's identified as a foreign substance, but it's misidentified essentially by your immune system, because it identifies not only that foreign substance, but a piece of your own cell, usually a protein, as foreign as well. So that builds a big antibody because this binds to the mast cell, and when you the normal thing, the antibody is good if it were just to the foreign substance. Because the next time you took that foreign substance in, whether it was a virus, whether it was a protein, whether it was a drug, an antibiotic, it would be neutralized by the antibody in the mast cell. Unfortunately, it also identifies parts of you as being foreign, so it will cause an inflammatory response in certain target organs. And when the mast cell degranulates, it releases histamine, it releases slow-reacting substance of anaphylaxis, it releases bradykinins, all sorts of things that are vasoactive, that cause the wheal, the hives, that cause laryngospasm, that cause bronchospasm, that cause cardiovascular effects, mostly vasodilatation. So, and anaphylaxis is an overreaction to what should be a life-saving thing or an illness-preventing event. So you get the first exposure, you make the antigen, it's in the mast cell, it's in the basophil. Re-exposure, the antigen it makes the mast cell degranulate, will cause a release of all these active substances. The histamine we treat with antihistamines. The true anaphylactic reaction we have to treat with epinephrine for the significant effect on your vascular system and the larynx and bronchi. Now, then there's complement-mediated anaphylaxis, which can be antibodies formed due to mismatched blood administration. It's getting to be pretty uncommon. And hereditary angioedema, which is poorly understood and is treated now with a bunch of interesting medications which are not yet ready for prime time, i.e. they're not yet ready to be released into the paramedic thing. So we would treat anaphylaxis pretty much you normally treat anaphylaxis. It doesn't work as well because it is not histamine related. Non-immunologic anaphylaxis, there are certain exogenous substances that cause mast cell degranulation all by themselves. Now we know that very well. We used to use morphine very commonly, and people, you give it intravenously and they get a big red streak up their arm. That is not a true anaphylaxis, and that's not I mean, it's not classic anaphylaxis. It's a release, it's a morphine causes the degranulation of mast cells. One of the reasons we always got hypotension, we could often get hypotension, and we thought it was due to simple vasodilatation, but it's releasing histamine. So we took that out of the orders a couple of years ago and substituted fentanyl for that, and we have very, very few reactions of hypotension after getting the fentanyl. Radiocontrast dyes, so X-ray dyes, cause degranulation of mast cells. It's treated like anaphylaxis, but it's not true anaphylaxis. Certain depolarizing medications will cause that, and dextran, which is one of the, remember, 5 years ago we had the hypertonic saline study, and one of the things was hypertonic saline with dextran. One of the solutions, you didn't know which one it was, that could cause anaphylaxis, and this kind of anaphylaxis, non-immunologic. Then there's idiopathic anaphylaxis, and as you all know, we call that idiopathic because we don't understand the pathology because we're idiots. Now, anaphylaxis. All forms of anaphylaxis, clinical features, significant anaphylaxis, diffuse urticaria. Now, often when you get there, the urticaria has gone. The rash has gone because they're in the hypotensive phase at that point. So you may be able to elicit a history of a rash, even if it's fleeting. Also, itching. Rash, itching equals urticaria. So if they said, I didn't see a rash, but boy did I itch for a second or two. Then angioedema, and it may just be of the face, maybe of the tongue, maybe of the uvula, maybe angioedema involving the entire pharynx. Other symptoms can occur and are true anaphylaxis. Abdominal pain, basically they're having ischemic vasospasm. Nausea, vomiting, bronchospasm, rhinorrhea, conjunctivitis, dysrhythmias occur, hypotension, laryngospasm. Typical features usually occur within 60 minutes of exposure. More severe, faster. Now, sometimes patients will get a biphasic reaction. They get a return of symptoms after resolution of the initial attack due to slow release factors, leukotrienes. So, you may treat the patient. They have moderate anaphylaxis. You think, well, it's true anaphylaxis. I'm just going to give them Benadryl because they're not really bad. They may be getting better because you knocked off the histamine part, but the leukotrienes come back. I mean, they're still circulating, and their effect is late. So if you have true anaphylaxis, you've got to treat with epinephrine. Your best bet with diagnosis is history of exposure. If they have a prolonged delay, they got stung and they don't have a reaction for an hour, that may confuse the issue. If they collapse in the field mowing the grass, the observers may think they had a heart attack. Treatment. Epinephrine. IV, and you know I like to give it by titrated by a drip. So your dose is 1 milligram of 1 to 1,000 in 500 cc's, which gives 2 mics per cc, or 1 milligram in 250 cc's, which gives 4 mics per cc. I don't care which bags you carry, titrate to that effect. I'd usually start it at 2 mics to 4 mics per minute, increase every minute as needed, titrate blood pressure, heart rate, PVCs and the reaction of the patient. Child gets 0.1 microgram per kilo per minute, increased as needed. Now, we don't give sub-Q epi anymore. IM epi could be given. So you have difficulty starting an IV. I don't think really that every patient who you can't find an IV in needs to have their tibia drilled. So you could give, if you had a significant anaphylaxis going on, give 0.3 milligrams to an adult of epinephrine. Child gets 0.01 milligram per kilo IM. Now, you notice we don't give it intranasal, we don't give it sub-Q, we don't give it under the tongue. I've been reading a lot of stuff around the country. So, now, if you had a terrible reaction, I mean the patient was dying on you, you could give, now, I still would like the drip, but, and that generally has worked. And we've been doing this, what now, for 20 years almost in this county. And we always have good luck. And when the nurses turn off the thing, the rash, the anaphylaxis comes back, so they turn it back on. A severe reaction, if you're thinking actually, you know, the patient's moribund, the patient is dying, they could get, could use 1 to 10,000, give 0.1 milligram, so 1 cc IV repeated every 3 to 5 minutes. I don't think that's, I don't think we've ever seen that necessary. Generally speaking, the drip works excellently. Airway management, early intubation as needed, fluid administration. Benadryl is second-line therapy, 25 to 50 milligrams IV, child 1 milligram per kilo. That is for that's the antihistamine. Med-Neb for wheezes. If it wheezes, treat it with Med-Nebs. Albuterol, you don't necessarily have to put the Atroben in it, but it doesn't hurt. Solumedrol, 125 IV, 2 milligrams per kilo for a kid. This is to stabilize the mast cell. It doesn't work immediately, but it will get that rebound. Okay, questions, and then you get to take a break. Okay, take a break. We will read poisoning in general. General treatment of poisoning. If the patient is ingested it, if it's a responsive, alert patient with a gag reflex, we'll give activated charcoal, 50 grams. Child gets 1 to 2 grams per kilo oral. Now, it has to be mixed with the sorbitol because it makes it sweeter and you can.
I don't think your mic's on.
It should be on. You're right. It's not making any noise. That's a battery issue. Light on. The lights on. Oh, good batteries. We'll see if they got a new battery here. I'll just yell.
Okay. Works for me.
Now, unknown ingestion, depressed respirations. Establish, protect airway, Narcan, glucoscan, if hypoglycemic, treat per protocol. If alcoholism is suspected, thiamine, 100 milligram along with it. Now remember, to be honest, you do not need to give thiamine if you don't give glucose. Just tuck that away. But we like, you know, if someone is clearly, if you really have significance about alcohol, thiamine, somewhere along the line. We're going to give it to them anyway. So, EKG, treat dysrhythms, cardiac arrest, that protocol, etc. So, specific poisoning: calcium channel blocker, beta blockers. Signs and symptoms, starting out with nausea, vomiting, headache, dizziness, confusion, profound hypotension, and cardiac dysrhythms, particularly bradyrhythms, bronchospasm, pulmonary edema. If they have congestive heart failure, congestive failure is worse. It makes it worse. Now, calcium channel blocker or beta blocker. You may not know which it is. You may just suspect it's a blocker because they have heart medications available, or it's a little kid who's taken some of mom or dad's or grandpa or grandma's medication inadvertently. For hypotension and bradycardia, atropine, 0.5 to 1 milligram standard child dose, 0.02 milligram per kilo. That probably won't make any difference, but you try it first. Then calcium. We carry calcium chloride. Calcium gluconate is more expensive. We may go to calcium gluconate because calcium gluconate works better for a couple of things. Calcium chloride, you're just trying to get calcium into the patient, particularly if there's a calcium channel blocker. An adult, 250 to 500 milligrams IV. Child, 20 milligrams per kilo. Glucagon, 5 milligrams IV for the adult, 0.1 milligram per kilo for a child. Now, that's going to crank up your mitochondrial system, the ATP, ADP, AMP system. Going to make it work better. Fluid challenge. Always, if they're still hypotense, if they're still bradycardic, it can be paced. You can pace children. You have pacer pads for that. My preference, if they were hypotensive and bradycardic, would be to try epinephrine drip first, and that's it. Start at 2 mics per minute and increase as needed. If you need more for pressure, then go to dopamine, 2 to 10 mics per kilo per minute. For rate, epinephrine works better. You may still have to add, because with the epinephrine you get both alpha and beta effects, so you may not get a real jump in your blood pressure. So you might have to add dopamine to it. Generally speaking, if you've gone through most of the things, you don't have to repeat that much. Now, the glucagon, 5 milligrams per, how much do you carry on a rig now? Maybe 2 amps, so you've got 4 milligrams. You're going to have to steal some from fire at that point. Now, the hyperadrenergic syndrome, common agents: cocaine, methamphetamine, MDMA, or ecstasy. So hyper, tachycardia, agitation, diaphoresis, mid-drive, large pupils rather than meiosis, little pupils, as in the opioids. Hypertension, hyperthermia. Now, the worrisome thing is going to be in hyperadrenergic induced arrhythmias, chest pain, seizures, and maybe stroke. But to treat the arrhythmias or chest pain in the hyperadrenergic system, the first thing is Versed, 2.5 to 10 milligrams IV. If they have a stable VTAC along with it, amiodarone would be probably the drug of choice at this point. And with VFib, treat per protocol, but keep your epi, because more adrenergic stuff, keep your epi down to a milligram every 5 minutes. Now, I don't know that we've ever had a hyperadrenergic syndrome patient in VFib. Now, of course, I don't know that maybe some of our VFibs weren't hyperadrenergic, weren't cocaine or methamphetamine induced.
If the patient was unstable, would you expect a cardioversion to lower the rate in an SVT?
Not necessarily. I'd load them. Now, the nice thing about it, if you're going to cardiovert them and they're awake, you're going to give them a good dose of Versed. I would give them a full dose. I'd probably give them, the 10 milligrams of Versed for sedation and cardioversion. Now, the problem is, that's a good question, because it's going to, it may not respond to that. Tricyclics. Symptoms, signs, dry mouth, blurred vision, urinary retention, constipation. Interesting questions for you to ask, How are they going to complain about? Are they going to complain about that to you? Probably not. There are severe toxicity, confusion, hallucinations, hyperthermia, respiratory depression, seizures, tachycardia, hypotension, cardiac dysrhythms, particularly wide complex tachycardias. So remember, these are drugs. Tricyclics will cause torsades. They will cause a VTAC. So amitriptyline, doxepin, amoxicillin, nortriptyline, imipramine. We still have those out there. They still give them out. There's a very tight, there's a very close difference between therapeutic and toxic dose. So our treatment of this hasn't changed much in years. Hyperventilate, you're going to make them a little bit. If you hyperventilate, if you're assisting hyperventilate them slightly. You're trying to increase their pH, lower their CO2. Treat hypotension with a fluid challenge first. If they're tachycardic greater than 110, or if they have a widening QRS. Now, if their QRS, if it looks wider to you, it's not yet over 0.12. But if it looks like it's wider than it should be, go ahead and treat it. These things, the stuff works in an overdose. The symptoms go from mild to severe in a very short period of time. So, first thing is to alkalinize the serum, which basically shifts the tricyclic away from the cell, a milliequivalent per kilo of sodium bicarbonate as a push, and then add an amp, 50 milliequivalents to the IV bag for the drip. That will effectively alkalinize the patient. For wide complex tachycardia or a widening QRS, magnesium, slow push, child gets 25 to 50 milligrams per kilo. Now, the newer antidepressants, including trazodone, bupropion, and the SSRIs, they don't have the severe cardiotoxic effect usually that the older antidepressants, the tricyclic, have. They're characterized by drowsiness, tremor, nausea, vomiting, tachycardia. Associated, though, with some of these, you can get what's called the serotonin syndrome. probably will complain mostly of shivering, fever, hypertension, tachycardia, nausea, diarrhea. On their CNS effects of an overdose, mental confusion, mania, hypomania, hallucinations, agitation, coma. They can also have myoclonus, hyperreflexia, and we treat that symptomatically. If they're confused, agitated, you might need to treat them with something like an absinthe. Opioids. Well, once again, we see a lot of opioids. Heroin, morphine, fentanyl, but like I say, this last year, both Oregon and Washington had as many deaths from from legal opioids as from the illegal opioids. Major signs and symptoms are all effects of CNS depression, respiratory depression, and most of your opioid and even synthetics will have constricted pupil. I say most because a couple of them don't. Treatment: glucoscan, 100% O2, thiamine if you think it's alcohol abuse. Narcan dosing regimen is, and it can be given IV, intranasal, intramuscular, and there's been recently several studies on patients who did reasonably well, particularly if they were not in respiratory depression, if they had respirations but were just CNS depressed, using Narcan by MedNet. Allegedly gives a very smooth ride out of their overdose, but you know, it does require that they're breathing. So the treatment for respiratory depression for an adult is, I still want you to give them 2 milligrams. I mean, we're wanting to treat respiratory depression. We don't care if they wake up, and if they wake up a little sharply. 2 milligrams IV or intranasal or IM. A child gets 0.1 milligram per kilo. If they just have altered mentation, are still breathing normally, their O2 sat and their EtCO2 is normal, titrate them to 0.5 milligrams of Narcan as needed to maintain airway and respirations, and they will wake up. Now, when are you likely to do this? When you get called to a nursing home or to a hospice or something, when they shouldn't be calling you anyway, because the person their LOC is depressed, but they're still breathing okay. Their O2 sats and everything is normal, and you don't want to shock them awake and have them withdraw because they've been on chronic. If they've been on chronic opioids, so titrate the dose. Now, a couple of new fun things out there, which we've seen a lot of in the last 2 years. Synthetic marijuanas, called incense or potpourri or plant food. Clever advertising. There are alternatives to THC, to cannabis, developed by pharmaceutical research. However, they've not been tested on humans. This doesn't go through the regular FDA process. And as a matter of fact, these are out there not as drugs. They are mostly come from overseas sources. The brand names are everything from Spice and Purple Haze, Mr. Happy, I like that one, the Mad Hatter, Crazy Kush. Now that's, you know, that's out of my way of thinking. Maybe something closer to you. So what they do with this, use alcohol or an acetate, acetone type of thing to dilute the substance. They spray it on herbal leaves, dry it, package and sell it as spice. You can add scent and flavoring depending on your specific audience. You smoke it or brew it as tea. They come from good sources, the distributors. Head shops, gas stations, convenience stores, tobacco shops, and by the internet. In little tiny silvery plastic bags. Now, interestingly, they bind to the same receptors as THC does, so it binds to the cannabinoid receptors in the brain. But they bind a lot tighter. Also may bind to the NMDA, the ecstasy site in the brain. So you can get some similar effects as PCP or ketamine. Remember, ketamine is used as a hallucinogenic. It's not why we use it, but we use it as a hallucinogenic. Methadone. You can get a lot of psych and behavioral and physiologic effects. Now, the desired effect would be calmness and alleviation of nausea, which is why people go to cannabis. But the actual effect of synthetic marijuana has been anxiety, agitation, hallucinations, paranoia, psychosis, suicidal, homicidal ideation, and attempts. And there's been several successful suicides reported with synthetic marijuana. Physiologic effects: vomiting, tachycardia, hypertension, chest pain, dyspnea, shortness of breath, tremors, seizures. Sounds like good things. Treatment is supportive. Keep the patient calm, restraint is needed, and our chemical restraint thing for, if you think this is if you're going to chemically restrain somebody who's acting odd because of a drug, our first drug is Versed. 2.5 to 5 milligrams IV. You can repeat it. If the patient is still agitated, not controllable after that, then you go to the next drug, which would be droperidol. But start out with Versed. Now we have the other newest thing, bath salts. Synthetic cathinones. Bath salts have similar effects as methamphetamine, ecstasy, and cocaine. They also can contain other illegal drugs. It's a naturally occurring active ingredient in the khat plant. These derivatives have not previously been regulated by the FDA. It was thought to be not in the FDA picks up things slowly, but they're now starting to regulate this. But these things are all non-regulated. I love the names: Tranquility, Serenity, Charlie Sheen. Now that has to be a drug. You know, the only one that would have been better would have been Mrs. Charlie Sheen. Cloud9, white lighting, and plant food. That would be a good thing to have. Plant food. You can smoke this. You can crush it, snort it, inject it, etc. It's sold, again, in head shops, convenience stores, and by the internet. Little plastic foil bags, usually 200 to 500 milligrams per package. Powder form, crystal-like, various colors. Onset is 30 to 90 minutes. Half-life is about an hour and a half. Duration of effect, maybe 4 hours. It increases neurotransmitters in the brain, including dopamine and serotonin, leads to stimulation effect, and just like PCP. So, agitation. You can't, nothing will stop you. Severe aggressive behavior, paranoid delusions, acute psychosis, psych behaviors similar to PCP use, homicidal ideation and attempts, self-harm, etc. They don't know if these will cause they probably will cause long-term effects, as does amphetamines, as does methamphetamine, etc. Commonly get nosebleeds, particularly if snorted, nausea, vomiting, hypertension, tachycardia, etc. So it's hyperadrenergic. Hyperthermia, CNS toxicity, treatment, supportive, scene safety, and your hyperadrenergic protocol, which is Versed. If the Versed doesn't slow them down, go to droperidol. But give a full dose of Versed. Caffeine energy drinks. I love these. There's no regulation whatsoever of caffeine. I've had at least 3 cups today myself. Caffeine overdose is a serious problem, particularly among young people. It's available, it's convenient, it's legal, low cost, good marketing. Caffeine energy drinks have almost as much caffeine as coffee, but in larger quantities now. So this shows the amount of caffeine per serving. This is an 8-ounce cup of normal coffee. This is 5-hour energy extra strength. So if it's 100 milligrams of caffeine per coffee, it's 242, 2.5 times more. Rockstar, also the same. High performance energy drink, yep. Monster is almost the same. 5-hour energy in general, they're all in the 225. Lots and lots and lots of coffee. Now, for those of us who like to bike, the Cliff Shot Turbo Energy Gel has 133, so it's a little bit more than a coffee. Interestingly enough, Starbucks Double Shot is lower than a regular 8-ounce coffee. Huh. So there's a fair amount there's a lot of caffeine in there. So caffeinated energy drinks are most commonly used by preteens, teenagers, young adults, people who want to stay up all night and study, or athletes before games, during games, partying, mixed with alcohol and other drugs for that extra special kick. Adrenergic symptoms, caffeine, insomnia, irritability, nausea, tachycardia, hypertension. In the toxic amount, SVTs, sinus tach, SVTs, lethargy, coma, tonic-clonic seizures, hallucinations, hypokalemia, altered kidney function, rhabdomyolysis. Not good things. Treatment, supportive. EKG monitoring, treat per protocol, treat with the hyperadrenergic as a hyperadrenergic drug as well. Okay. Phenothiazine dystonic reaction, we see those mostly because we cause it, because we use something like, in our experience, we'll use something like, we'll give a patient some droperidol. And generally speaking, in my experience, it's been a less than normal dose of droperidol. We've given them a little bit less, but sometimes we'll get called to a patient who's taking a drug for nausea, compazine, or one of the compazine-like drugs for nausea, and they'll be complaining of uncontrolled contraction of muscles of the face, neck, or back, fasciculations of the tongue. Sometimes they feel like their tongue is protruding outward. Oculogyric crisis, eyes look upward and they can't look away. They know they're going to, of course, die at that point. Laryngospasm is rare. They get better with, they can, if they're getting a contraction of the muscle, they can still do a voluntary move, and that decreases it a little bit, but they'd be very frightened. They don't like this sensation. Then there's the other end of the dystonic reaction called akathisia, where the patient doesn't have these symptoms, but they simply have that creepy, crawly skin sensation. And they get very agitated and emotional. Nevertheless, so this sort of shows the kind of neck kind of things that they get all twisted up and they can't, and this comes and goes often, and they get very, so compazine, stelazine, haldol, anapsine, promethazine, they all can cause anything, any of the phenothiazine derivatives can cause this kind of reaction. You're going to see it mostly because you gave them a dose of droperidol and then they feel creepy, crawly skin and they get a little agitated. Do your initial primary survey. If you think it's a phenothiazine reaction, dystonic reaction, Benadryl usually takes care of most of those reactions. 25 to 50 milligram IV for an adult. IM, it also works, but it's much slower. If they don't get relief from the Benadryl, and that's generally in the after 2 to 5 minutes, if they still have that creepy, crawly, the akathisia, usually the true dystonic reaction goes away pretty quickly with the Benadryl. If they have the akathisia, the creepy, crawly thing, you may need to give them a little kiss of Versed, like 2.5 milligrams of Versed, and that stops it. Organophosphates. Remember the toxidrome, it inhibits acetylcholinesterase, allowing cholinergic hyperstimulation. Muscarinic stimulation, get smooth muscle contract, causing airway constriction. You get mega secretions from all these secretory glands, tear ducts, or tear glands, nasal mucous membranes, or the salivary glands and the glands, the secretory glands in the bronchial system. So you get mega secretions, and you even get sweating too. So there'll be tearing, snotting, foaming at the mouth, and have bronchorrhea, have lots of secretions. The nicotinic portion of the cholinergic hyperstimulation causes skeletal muscle contraction and twitching mostly, because and will also, you won't see the bradycardia because, or you won't see tachycardia because the bradycardia caused by the muscarinic stimulation will override that. So salivation, lacrimation, urination, defecation, increased GI mucus as well, emesis, so SLUD syndrome. Now we're talking mostly organophosphate insecticides, but that also includes the carbamates. So if you have a suspected exposure with that kind of a syndrome, you should be able to guess it, particularly if they're laying there, with an open bottle of insecticide in front of you. Now, how do you know that? Well, I think the best case we have ever seen was a guy who slept. He woke up in the middle of the night. He had a cough. He'd had a cough for some time, so he kept a big bottle of cough medicine in the nightstand next to him. So he gets up and takes a full slug of this stuff, and then lays down and begins coughing worse and foaming and snarting and salivating and having all sorts of, and vomiting and defecating. And his wife became concerned about that. And it turns out that he also kept in his nightstand a big bottle of this concentrated insecticide flea dip for his dogs. Now, why he would put them in the same nightstand in the same deal, I have no idea. But that's what he took in the middle of the night, because he just did it in the dark. So he had the classic case, and he required atropine. And the atropine you give for this is 1 to 2 milligrams IV every 5 minutes until they dry up. And by the time they got to the ED, we had used up all the atropine on the rig. And then Steve Pliska got to treat the patient, and he used another 20 milligrams of atropine in the next hour, and then put him on, and then also got 2-PAM into him, because that's the ultimate thing. You need to get the pralidoxin or the 2-PAM into them at the same time. Now, you don't carry that except in the Mark 2 kit. Versed for seizures, treat seizures per protocol. So that pretty well covers. If you have any questions on this stuff up to this point? Let's see. Yes? Okay. I have a couple of case reviews. Okay. Respiratory arrest. Now, this one relates to our overdosing. 47-year-old female who was on the bathroom floor, found by husband unresponsive after using heroin. She'd also taken an unknown amount of Xanax. She'd been drinking vodka. He did CPR on the patient prior to arrival. Doesn't know how long she was down. Past history of substance abuse. Her last overdose was on 6/06 of this year. This is about 6/12. Recent hip surgery, hypertensive, Hep C positive, on alprazolam, lisinopril, clonazepam. 90-kilo female in the floor bathroom, unresponsive pain, agonal respirations, dusky in color, cool diaphragmatic touch, strong radial pulses noted, copious amount of vomit on floor and an oropharynx, had been incontinent, probably seized. Lung sounds are diminished with wheezes and rales and rhonchi. Heart rate's 136, blood pressure 140, respiration 10 assisted, O2 sats 90%, glucose 166. She ultimately got intubated, but she got some Narcan first. Initial CO2 was 50. Maintained in the low 40s, good waveform. So BVM got 2 milligrams of Narcan. Patient color and respiratory rate improved somewhat. Suction into oropharynx, additional 1 milligram Narcan. Now responsive to verbal, combative, states she can't breathe. Lung sounds, poor tidal volume, lots of wheezes and rhonchi. Vomit several times on the way to the ambulance. Decision to RSI. She got etomidate, lidocaine, succinylcholine. Now, just thinking about this, why did she get the lidocaine? Okay, so that's what I had to assume too, is they were thinking, oh, she's got reactive airway. Why do you think she has wheezes, rhonchi? Okay, that's one good reason, yeah, because she got vomit and stuff. What else do you know about overdoses of heroin? Ah, yes, non-cardiogenic pulmonary edema. So it's a good bet on this one. So she needs positive pressure treatment. So that was a good choice to do. That was a good choice to do the intubation. I don't know that she was a good would have been a candidate for CPAP because she's not very cooperative, let's say. So she was intubated. She had CO2 at 50 with a good waveform, and they checked the waveform several times because we looked, and it did well. And she gets transported to the hospital. She got some Versed for sedation because she's bucking the tube, got some additional Versed, vomit noted in the tube, so she did aspirate. She suctions, still moving, got some more Versed. Remember, she's probably going to use a lot of Versed. I'm glad that they didn't. I mean, this patient would be kind of a problem, or might not be a good idea to do a long-term paralytic. Good waveform, again checked, turned over. Treated for aspiration pneumonia, extubated the next day, psych consult, she's bipolar, polysubstance abuse. That hasn't changed. Left the hospital AMA, readmitted 5 days later for another OD attempt. Sooner or later, she's going to be successful. But good treatment, good care. I know the thought might have been for reactive airways. She didn't need the lidocaine, but it didn't hurt her either. Okay, this is I think this is a Camus case. This is a 13-year-old male, fell about 30 feet. Loss of consciousness, head, lower back, hip pain due to fall from a rope swing 20 to 30 feet. Witness reports patient swung across the ravine, appeared to slip off the rope and fall. With kids, built a rope swing like in this ravine that's off Croon Hill, I guess. And he doesn't remember the fall. He woke up to find EMS providers around him, which is a good thing that he was with other kids, because apparently he went in a place that you wouldn't have ever found him if he'd just gone into a hole, because it's just kind of brushy and everything. Hurts all over, rates of pain of 7 or 10, has the worst headache of his life. Denies neck pain, chest pain, shortness of breath, numbing, tingling, has allergy to peanuts. So, well, good. Mother ultimately reports patient has a past medical history of congenital left-sided facial palsy and paralysis. So a confusion at the scene, but is this a severe head injury, or is this a neck injury, or is this what's going on with this kid who's got left-sided facial palsy? Denies any other significant medical or surgical thing. Mother, of course, wasn't at the scene immediately. GCS 15, on arrival, airway patent, skin pink, muscular. Were any of you guys on the call? Yes?
Yeah.
So it was kind of a difficult approach?
Yeah, it was just a steep ravine, and the head of it was kind of like a cirque.
Yeah.
So the rope swing, you stand on terra firma, and then you swing over the abyss, and you let go.
So you had to take him out from below, right?
Yeah.
You took him out all the way down the ravine?
It was either that or a high angle.
Yeah. Okay. Trachea midline, no JVD, C-spine's okay, shoulder clavicle's okay. Laceration of face and jaw, bleeding control. Did you note the facial paralysis?
Yeah.
They didn't write it down, which is why I was wondering.
Yeah.
pelvis painful bilaterally, abdomen soft, non-tender, etc. Back with the lumbar spine tenderness, midline, no deformities. So patient's about 200 feet down, muddy ravine, in distress, assessed, controlled C-spine, baseline vitals, established IV, rolled to backboard, secured, moved to Stokes, extrication down alternate trail, had to relocate all the MS due to MICU, reassessed, transported code 3 to a manual because of the potential head injury. And
Yeah, the mother was a trauma nurse at Legacy Salmon Creek, which is a little oxymoronic, but anyway, she
Yeah.
wanted to.
because you're not a trauma center.
Oh, yeah,
Yeah.
So she wanted him transported there, but we opted for a manual because it's still in the system and
Right.
arguably could have gone there anyway.
Right. Blood pressure 135, 82, pulse 72, rate 20. Kid was discharged almost immediately. Had no significant things except for the little laceration. Well, this is good. But this is one of those things where the patient's past, it would have been nice to know all the patient's past medical history a little bit too. I guess she was at the scene ultimately, so told her about the facial thing. How old is he, 16? 15? 13. Yeah, well, did you contact medical control and say you were going over?
No.
Okay. Next time, just let them know. Okay. Code 3 and a fainting. Patient advised an episode of chest pain and fell while getting to the phone to call 911. Woke up on the floor, complains of weakness, denies chest pain, currently doesn't know how long he was out. Patient left lateral on the floor, talking with 911. Alert oriented, appears weak, sweaty, pale, intolerant, lying on the back. EKG shows a third-degree heart block, ventricular rate of 30, and atrial rate of 100. I think Mark is missing a page here. Blood pressure is 70, pulse ox 88, room air, pulse 30, glucose 167. In clinical interpretation, AV block, 3rd degree. Pacing, 90 milliamps at 60, 1 capture detected. Now, pulse rates, so moved it up a little bit. Pulse rate 60, blood pressure now 122/60, respiration is 18. He's complaining of pain. He's yelling. Now he became very sedated, but was arousable to slight external stimuli, so you did well with that. And pulse oximetry rises to 99, ultimately vital signs, blood pressure 118, pulse rate 60, paced. In hospital, complete heart block with an ejection fraction of only 30 to 40%, coronary artery disease, anemia, kidney disease, hypertension, IDDM, got a pacer defibrillator, monitored in the CCU without issue, discharged home in 3 days, doing well, normal. Case 4, 84-year-old male in cardiac arrest, eating at a restaurant alone when employee noticed he slumped over. Probably noticed it when he brought him the bill. When patient was checked and found not breathing, they called 911. Taken to the floor by bystanders, and bystander CPR started, which is good, unusual. No one on the scene knows the patient, so they didn't know anything. He has a large scar in his chest, possibly from open heart surgery. So, bystander CPR is in progress. Took over, analyzed rhythm, VFib. Shock number 1, an IO was started in the right tibia. Continued CPR, analyzed rhythm, V2. Shock number 2, continued CPR. Traditional intubation attempt unsuccessful. Too much food in the airway. He is in a restaurant. Bubbles but no vocal cord seen. Got epi, got ALPS, 1A and 1B. Analyzed rhythm, VFib. Shock number 3. Traditional intubation attempt number 2, still unable to visualize. Continue CPR, 1 milligram epi, analyzed rhythm, ROSC. Strong pulses, moved to gurney. To ambulance, transported code 3. First intubation attempt with King Vision, successful. Confirmed, good waveform. Second IV started, hypothermia fluid started. Patient attempting to breathe unowned. SpO2 82%, doesn't appear to be accurate. First reading in ED shows 99%. ETCO2 25, blood glucose 246, heart rate 102, left bundle branch block, no concordance noted. Continued with hypothermia protocol in the hospital, an amiodarone drip in ICU, currently extubated and speaking, normal mentation, future care to probably get an AICD. So he went home and he was normally mentating. So this is a good one. And remember, this was an ALPS case, and ALPS was given at in the same time as the epinephrine. So quickly, to recapitulate, I think the word is getting out. ALP inclusion criteria. Non-traumatic out-of-hospital cardiac arrest, vascular access, IV or IO, persistent or recurring VFib, VTAC after 1 or more shots. And you can't use any open-label amiodarone or lidocaine. There's a couple of things that we don't do. We can't treat prisoners, minors, pregnancy, etc., and people with a no-study bracelet. We have not seen yet a no-study bracelet. What counts as a shock? Any shock given by any agency or any non-agency, including a public access defibrillator shock, because they will only shock VFib or pulses VTAC. So any ROC agency, any first responder agency, AED shock, any ALS delivered shock, any non-ROC PAD shock, but not ICD, not internal cardiac defibrillator shocks. We don't know what those are due. We don't know what those are. We can interrogate all of our other devices. What's persistent recurring VFib? Confirmed VFib pulses VTAC anytime after the first shock. So when you think I'm going to give an antidysrhythmic drug per my protocol, you will now use the ALPS drugs. Give them as soon as possible, like this one was given. Within 10 minutes or less after arrival. Study drugs can be given immediately following epinephrine after you flush the tubing. What if VFib, VTAC returns? Carry out the full ALPS protocol. If you give 1A and 1B, and that's the normal dose, first dose of ALPS drug is 1A, syringe 1A and 1B. If you get recurring VFib, or if it's persistent VFib after that, you give the next dose, which is dose 2. In this case, they didn't have to give syringe 2 because he got ROSC. So if they get the pulses VFib, VTAC after giving the first dose, shock again, and then give syringe 2. Late recurring VFib, VTAC is treated the same way. So if you're driving them to the hospital and they go into VFib, VTAC, and you shock them and they come back in VFib, VTAC, give them the ROC, give them epinephrine and the ROC drug. 2 syringes for most normal adults. If they're little tiny people, like below 90 pounds, then give them only syringe 1A. Second dose would be syringe 1B. If one or more of your syringes is broken when you open the thing, then the patient is automatically out of, we have to report it, but they're automatically out of the study, and you can go to your standard protocol, which would be amiodarone. You got to use the clear link adapter because it doesn't work. The glass syringes don't work without that clear link adapter. And put the clear link adapter on your IV port, and then put the syringe on that. Syringe goes on a little half turn. If you enroll a patient, call the number. It's in your. You don't have to remember. It's in your forms. Because we have to notify the patients and the families that they were enrolled in the study. That the hospital emergency department know that the patient has been enrolled in ALPS. And you give a little piece of paper so that the ER doc can figure out whether if he or she needs to give more medication at that point, what they can do. Document, 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 your normal thing, but it's critical to upload your CPR process file, your PCO file. Timestamp each dose if you can. Document the shock number that follows each dose of ALPS drug, study drug kit number, barcode, etc. So, good job. We haven't had any missed ALPS in the last 2 months, so don't make me feel bad. All right, remember, no PCEP in August by tradition. So we'll see you in September.